Good evening, aspirants. So today's class is on organophosphorus poisoning and it will be taken by Dr. Asif Iqbal. So, sir, you can start the session. He's a senior
Yes.
consultant critical care, Apollo Hospital.
So, good evening, guys. Today I'm starting case how to approach organophosphorus poisoning. My Indian student, they know that organophosphorus poisoning is a very common problem in India, though in the Western country you will not get organophosphorus poisoning commonly. But for any Indian critical care exam, you have to know about the management of organophosphorus poisoning. And now this year also the EDIC included this organophosphorus poisoning in their exam questions. So a case scenario, 30-year-old farmer is brought to the emergency, have been found unconscious in his room, his family being alone, an empty container of weed killer. On evaluation, you notice peculiar odor. He has a delirious, coding from his mouth, pinpoint people, pulse 40 by 40 minutes, BP 130. Excuse me. Uh, So pinpoint people, pulse is 40 per minute, BP is 170 by 100, weight himself. So what will be your walking diagnosis, and how will you manage him? So this is quite obvious that patients suffering from some poisoning and commonly use weed killer as a organophosphorus. So how will you approach? You have to take a good history, good clinical examination, look for toxidrome investigation to look specific substance. General management principle is same like initial supportive care, prevention of absorption, enhancement of elimination and antidote, and along with the ABC, you have to the airway, breathing, circulation, and especially when you are dealing with organophosphorus poisoning, you have to cut off the absorption. So good history is very important when the poison has taken, and whether this poison is on the cloth or not, because it can go inside by three route: the uh, skin absorption, dermal absorption, inhalation, and ingestion. So that's why you have to clean the patient very well, and to remove the all skin contamination, and second, stop inhalational injury, and if possible gastric lavage if the time is less than 2 hours. So organophosphorus compound OP and carbamate are potent acetylcholinesterase inhibitor in neuromuscular junction, CNS, RBC, and plasma, and cause severe cholinergic toxicity, acute and muscarinic and nicotinic side. Poisoning occur through cutaneous exposure, inhalation, or ingestion. And opioid, this organophosphorus compound linked to human poisoning are there are multiple parathion, pentathion, malathion, dazinon, and dersman. Carbamate is methomyl or LD carb. Then toxicdrome of OP poisoning, conventional classification, cholinergic effect, autonomic nervous system or muscarinic effect, and neuromuscular junction, nicotinic central nervous system, both muscarinic and nicotinic effect. Muscarinic sign and symptom, heart and smooth muscle, nicotinic effect via receptor of neuromuscular junction, fasciculation, muscle weakness, paralysis, CNS, nicotinic and muscarinic receptors, central respiratory depression, lethargy, excitability, seizure, coma. So there are two mnemonic you have to remember. One is the sign symptom is dumbbells, defecation, urination, meiosis, bronchoria, bradybronchospasm, emesis, lacrimation, salivation, and this mechanism is analogous to the depolarizing effect of succinylcholine in producing neuromuscular blockade. Just 1 minute. আমি একটা অনলাইন ক্লাস নিচ্ছি। ঠিক, হ্যাঁ কেন? ঠিক। So toxidrome of OP poisoning, time of symptom onset, acute, delayed or late. Acute poisoning, minutes to hour, feature depend on age-related acetylcholine esterase inhibitor, route of absorption, oral or respiratory exposure uh, in three hours. Dermal exposure take up to 12 hours. And agent need to conversion to active metabolite. Lipophilicity of the agent is lipophilic agent has delayed onset up to 5 days and prolonged illness 30 days. And that acute toxidrome mostly muscarinic symptom that is called sludge. If you remember the mnemonics, salivation, lacrimation, urination, defecation, gastric cramp, and emesis. So you just remember the sludge, nicotinic sign and central sign. Already I have described fasciculation, muscle weakness, paralysis, these things. Next, time of manifestation mechanism. So acute, minute to 24 hours, nicotinic receptor, weakness, fasciculation, cramp, paralysis, muscarinic receptor, already mentioned the slash, central receptor, anxiety, restlessness, convulsion, respiratory depression, delayed 24 hours to 2 week, mainly nicotinic receptor intermediate syndrome. We will explain when we will discuss about the management regarding the intermediate syndrome. We oftenly found in the ICU patient who come with your organophosphorus poisoning. Muscarinic action, cholinergic symptom, bradycardia, meiosis, salivation, central receptor coma, extrapyramidal manifestation, and late beyond 2 week. Usually peripheral neuropathy is coming is more or less like intermediate syndrome with there is a peripheral neuropathy. Diagnosis of OP poisoning, one is a clinical diagnosis and second is lab assay of acetylcholinesterase. In RBC acetylcholinesterase was plasma or pseudocholinesterase. RBC acetylcholinesterase good marker of synaptic function level, provide measured degree of toxicity. Pseudocholinesterase or butyryl cholinesterase do not correlate with severity of the poisoning, should not be used in the guide of therapy. Use detect exposure of OPC, measure OPC elimination from the body. So if one test need to diagnose and the prognosis, that is your RBC acetylcholinesterase. Approach to management, initial supportive care again. The step is clean the patient, prevent further exposure, and second, take care of ABC. Then even the mild and moderate OPC poisoning, consider early intubation. Avoid to use succinylcholine, because if you use succinylcholine, it can cause more fasciculation and prolonged effect. No depolarizing neuromuscular blocking agent can be used, but doses may be increased dose may be needed. Bradycardia, hypotension are common. Adequate volume resuscitation is very important before you are intubating patient. Otherwise, this patient may develop severe hypotension and crash. The prevention of absorption, skin contamination, ocular decontamination, and GI tract decontamination. GI tract decontamination by induced vomiting or gastric emptying by gastric lavage, activated charcoal combined with cathartic. So in OPC gastric lavage, no RCT confirmed benefit to be done only after initial stabilization. Treatment with atropine and oxpine consider only if the patient arrive within 1 hour of ingestion of the poison. Activated charcoal role, bind organophosphorus in vitro, no evidence suggests benefit from the activated charcoal. These are all supportive care if the patient come acutely within hour, because this organophosphorus stays in the stomach maximum 2 hours. So if the patient delayed respond in the emergency, then there is no role of activated charcoal. So enhancement of elimination, forced diuresis, urinary pH manipulation, multiple dose of activated charcoal, and extracorporeal removal of the toxin is hemodialysis, hemofiltration, hemoperfusion. RCT of multiple dose activated charcoal versus placebo failed to find any significant benefit. Role of hemodialysis and hemofiltration are not yet clear. So OPC, which has poor stability in poor solubility in fat and small volume of distribution, found in the benefit from in non-RCT study from the China. So because its molecular size is high and it is not very much lipid soluble, so it stays in the plasma level, and therefore hemodialysis is a good modality. Antidote therapy for OPC poisoning, muscarinic antagonist is atropine. Acetylcholinesterase reactivator is oxime. And early therapy is essential. Aim is to reverse cholinergic feature, improve cardiac and respiratory function. Atropine, glycopyrrolate, hyoscine, methobromide, scopolamine. This can be used as to reverse the cholinergic feature, to break bond between OPC and acetyl organophosphorus and acetylcholinesterase conjugate, regenerate the acetylcholinesterase. Here the oxime, paralidoxime, ovidoxime, and trimethodoxime can be used, but the newer guideline also has not very strong recommendation on the oxime use. So how atropine work? It is an anti-muscarinic agent, compete with acetylcholinergic as a muscarinic receptor, prevent cholinergic activation, and parenteral into even it penetrate into CNS, logically first choice of PC, and does not bind to nicotinic receptor. To main adverse effect is anticholinergic delirium. So atropine dosing 1 to 3 milligram atropine IV bolus or 0.05 milligram per kg IV for children. Double the dose every 3 to 5 minutes until desired response. And response pulmonary muscarinic signs are alleviated. This has to be achieved rapidly, prevent type 1 muscle paralysis. Start infusion of atropine giving 10 to 20% of the total dose per hour. Monitor patient often, adjust infusion rate appropriately. Therapeutic endpoint, clearing of the respiratory secretion and cessation of the bronchoconstriction. Tachycardia, mydriasis are not appropriate marker of therapeutic improvement. In your exam, this is very common question, when you will stop atropine infusion. So your therapeutic endpoint one is the secretion, whether the secretion stop, dry or not, and the bronchoria and the bronchoconstriction. So if you see the lungs air entry is good and not there is a no crackle sound, then and also you see that dry of skin and the mucous membrane, you can think about to stop the atropine. So atropine or glycopyrrolate, which will you give? The atropine and glycopyrrolate appear to be equally effective. Atropine is the first choice, especially when there is an early muscle weakness. Glycopyrrolate does not cross blood-brain barrier. Combine benzodiazepine or specific antimuscular drug with good CNS penetration, such as scopolamine, to reduce the central nervous system side effect like muscarinic effect, the irritation and your irritability and coma. So oxime, it cleaves the covalent bond between OPC and your acetylcholine conjugate. So it produces reactive acetylcholine esterase. The only drug have effect on the nicotinic receptor. Pyralidoxime is the first discovered used in the clinical practice, parathion poisoning, and other oxime like your obidoxime and trimethodoxime has been also used newly. The RCT is a high dose oxime who dose mortality 1% versus 8%, or this has been shown. The uses of the oxime is reduce the time of mechanical ventilation and the length of stay in the hospital. So who recommended regime of oxime therapy? Evidence of cholinergic toxicity, neuromuscular dysfunction, pyralidoxime dose IV bolus 30 milligram per kg adult or 25 to 50 milligram per kg in children. After bolus dose, continuous infusion 8 milligram per kg per hour in an adult or 10 to 20 milligram per kg per hour for the children. Adjust IV infusion based upon the patient clinical response. Several days of therapy may be required. No treatment have been shown to prevent the intermediate syndrome or OPC-induced delayed neuropathy. Effectiveness of oxime is a debate, and 2 RCT from Vellore noted low dose infusion of palidoxime might cause harm. 2 meta-analyses that followed the gave conflict result. RCT was done recently, showed no benefit regarding the palidoxime. So oxime has an acute organophosphate pesticide poisoning. The Cochrane collaboration meta-analysis show that current evidence insufficient indicate whether oxime are harmful or beneficial. Who recommended regime of the pyralidoxime chloride is not supported. Further RCT require examine other strategy or the regimen regarding the oxime used in organophosphorus poisoning. So reactivation of inhibited acetylcholinesterase T-hub reactivation varies with OPC, like dimethyl have half-life 1 hour, dimethyl half-life is around, and diethyl has half-life half an hour. So oxime speed up this reactivation. Aging of inhibited acetylcholinesterase. Acetylcholinesterase cannot be reactivated by oxime. So that's the failure. And if the patient has ingested diethyl OPC, it takes 33 hours, 50% get agent. Oxime can be effective up to 5 days after ingestion. That's why This molecule is not very popular like your atropine. So is there any relation between the hazard classification organophosphorus pesticide and outcome in suicidal human poisoning commercial organophosphorus formulation? So it has been found that in a commercial formulation has more mortality and delayed feature of organophosphorus poison 24 to 2 week. There is a some organophosphorus poisoning dichloromethane acute symptom 40 to 48 hour. They produce mainly the intermediate syndrome, delayed organophosphorus encephalopathy, and delayed onset of extrapyramidal and cerebral ataxia. So more commonly found intermediate syndrome. What is the intermediate syndrome? Actually, intermediate syndrome is uh, kind of thing that critical illness is more similar to critical illness neuropathy, where the muscle power is very less. Patient is very much conscious oriented, but muscle power is very less. So treatment for intermediate syndrome is your nutrition and exercise. So type 2 paralysis of OPC 24-96 hours after poisoning, cholinergic phase has settled down, neuromuscular junction defect has been demonstrated by electromyography study. Recovery is normally completed and without any sequelae 7 to 21 days. And main treatment is nutrition and your regular exercise. Muscle group affected proximal limb muscle, neck flexion, motor cranial nerve, respiratory muscle, focal weakness, laryngeal palsy sometimes. Late onset feature after 2 weeks is a neuropathy. So characteristic by distal weakness. The intermediate syndrome is a proximal weakness, and OP induced delayed neuropathy is a distal weakness. Cramping pain, paresthesis of the extremity followed by weakness and distal limb muscle. And the molecule target, the neuropathy targeted esterase, which is inhibited by OP. Recovery, here also the complete cerebral ataxia, extrapyramidal symptom can be there. In conclusion, the diagnosis of organophosphorus compound or carbamate poisoning is made a clinical group. An acute toxicity patient with manifestation of cholinergic excess, muscarinic and nicotinic. Atropine therapy is the appropriate and is the antidote. Oxime therapy still remain controversial, and the breakpoint of atropine infusion is your relief of bronchospasm and bronchoria, not your mydriasis. So thank you. Thanks for patience hearing. Is there any questions, student? Welcome, Gunodhar.
Hi, Dr. Asif. Asif bhai, all good, good presentation.
Good. Thank you. Thank
So
you.
you have covered almost all the parts. So just I would like to highlight you there are a few things like for the DNB particularly you have almost covered from the EDIC DNB prospect, but particularly when the organophosphorus
Yes,
when
Gunodhar.
like this,
Continue. Yeah.
yeah. So basically when this organophosphorus come is a short long case particularly. So there are three, four things. Like one is if from the theoretical aspect, the examiner sometimes wants to know about the WHO category of these toxic ingestion substances. There are four categories, I think. So this belongs to the highest category, category 4. And sometimes you also know the LD50, the lethal dose of this organophosphorus compound in different organophosphorus compound. So the lethal dose basically it's determined in the rat, but depending on the every compound has a LD50 which is written on that particular box, and depending on the particular LD50, sometimes you need to understand key how to need to prognosticate the patients. So lower the LD50, the more and the injection, more amount of injection. So particularly the prognosis is guarded. And if the like sometimes it's a substances which is like I can say nerve gases or neurotoxic, particularly sometimes the prognosis is guarded. There are different scoring systems are also there for prognostication of the organophosphorus compound. So what I want the students to go and read about the different scoring system, it actually helps in prognostication of such patients. And regarding the intermediate syndrome, it's like most of the bhaiva will go towards the intermediate syndrome. So typically the symptoms and sign resembles the case of your critical illness neuromyopathy, but the difference is already you highlighted regarding the distal, the proximal sparing, and the person is very much awake, conscious. There is a weakness of the neck muscles, which is the typical of this intermediate syndrome. And patients of intermediate syndrome, that takes long time to recover from the ventilator with tracheostomy. Sometimes they go into the rehab care and all these things. So, and the diagnostic criteria are like particularly the RBC is the true cholinesterase level and the pseudocholinesterase level, though they are not very good at diagnosing the condition, but they helps in prognostication and the severity. The drop in the pseudocholinesterase level after the injection sometimes give an idea. If there is a more than 50% drop, particularly it's like a severe case of organ OP poisoning. That is what the, and you have to see the trend of drop and trend of rise after you initiate the treatment. And as you already told, like the oximes, actually the role is still controversial. There are few studies, mostly all the studies of organophosphorus are from India, the India and the particularly the CMC Vellore, and some are from the Sri Lanka actually, because most of the cities in Europe they have banned this compound, so they will not get most of the OP poisoning cases in Europe and particularly in the US. But in India it is very rampant. So whenever any patient of such poisoning, you have to ideally tell the relatives to bring the bottle and content, which is like what kind of toxins it is, whether it is a carbamate or typical OP or neurotoxins, or it's sometimes the insecticide you have to classify, because that also helps in prognostication. Sometimes in case of carbamate poisoning, the oximes are contraindicated in those cases. So these are the only few salient points from my side. So, and the other thing is, one thing I would like to highlight here, that OP poisoning typically resembles the brain dead condition sometimes. In case of severe OP poisoning, the person will typically behave like a brain dead condition, like it's one of the toxicological mimics of the brain death. So unless until the 4.5 lives has been passed in the circulation, this patient will not get awake. So you have to wait and wait, and you can see all sorts of dilated fixed people, no cough reflex, nothing. They will just remain on ventilator, and sometimes there can be incidents of cases where we faced there is a massive rise in the ICP, of course, due to the direct neurotoxic effect, and that sometimes leads to severe bradycardia and hypertension and sometimes neurogenic shock. So these are the spectrum of the organ OP poisoning. So the patient, if they die, usually they die within 24 to 48 hours. But if they recover, then probably they go into the intermediate syndrome and then they take a long time, and they face all the critical care challenges. So this is all from my side. You have nicely, beautifully highlighted all the salient points, which is very important from the exam prospect, and particularly the recent evidence of literature also you have highlighted. And I think the students should go through this, one of the very burning and important topic.
Thank you, Gunodhar. Thank you. Student, you have any question? You can unmute yourself and you can ask. We have Dr. Gunodhar with us. Is very renowned teacher, academician and intensivist in Navi Mumbai Apollo.
Good evening, sir. Sir, how long we can the treatment? How long we can start the prolidoxim, sir, from the point of poisoning oximes?
Again, this is oxime nowadays is a controversial. So it is like atropine, there is a typical guideline when you have to stop atropine infusion. In palidoxim, there is no clear-cut guidelines, but you can continue until you have the muscarinic and nicotinic side effect is there. But all the RCT now is suggesting that palidoxim should not be used. So I don't know whether it is appropriate question nowadays or not. The examiner might not ask about the palidoxim now.
Yes, yes.
What is
True,
your
true.
take?
True. I think it's a controversial area. So unless until you are 100% sure that you are dealing with a typical OP poisoning and the patient comes within very early within 12 hours, or you can say within 6 hours of symptom onset, then only it has role. But all the studies like the WHO study and everything there, they don't suggest actually. So you have to just atropinize the patient, and symptomatic treatment is what is more beneficial compared to the oxime.
And sir, if the patient is coming after 4 hours of ingestion of organophosphorus poisoning, we should not give the gastric lavage for that patient, sir, because you told that after 1 hour, it is not recommended to give the gastric lavage, like because it will be absorbed from the stomach early within 1 hour.
Yes, gastric lavage, if it is a very acute onset and a patient is giving proper history that time, then
Okay,
there is a role of activated charcoal. But if it is a delayed, then there is no role. Still we do, but the evidence suggests that there is no role. The RCT shows that there is no role, no effect.
thank you. Thank you, sir.
Yes. And again, when you give a activate this gastric lavage, the most important thing you're like there is a high chance of aspiration sometimes. This patient may be drowsy, so the airway should be protected always. It is better to protect the airway and give a lavage. The chances of aspiration, because this patient they go into non-cardiogenic pulmonary edema, aspiration, hypoxia. So all these things will come into play. So it's better that you should protect the airway and then give the gastric lavage as soon as possible.
Yes.
Thank you, sir. Thank you.
I just want to ask, as a curiosity, how much atropine as per your experience you have used? How much means?
In my institute, the organophosphorus come very less compared to other institute. But we have found that maximum we have continued the organophosphorus, the atropine for 36 to 48 hours.
So means
That is the maximum.
how much amount, sir? Amount.
So it is
Uh,
basically not defined till the time the patient have bronchoria and more secretion. Sometimes 100 vials, sometimes
okay.
100 vials, sometimes more than that also. You have to tell your pharmacy to keep reserve as much atropine as possible. There is no fixed cut doses or guidelines that this is the amount of you give. You just look for the symptoms and look for the toxicity. Then you decide.
Yes. Thank you, sir.
Thank you, Gunodhar. Thank you, student.